type 1, we talked about the autoimmune destruction in the beta cells, right? Which beta cells in the pancreas, right? The islands of the Langerhans. In type 2, right? They still make insulin, but there is failure of the receptors, right? They're not working as effectively. You may also have progressive pancreatic B cell failure, but initially, in the initial phases, it's usually the receptors that are not, functional. If you're not making insulin by destruction of beta cells, you definitely need insulin always, right? So they're always going to be prescribed on insulin. Type 2 diabetics, depending how much insulin they make, they may be on insulin, right? Or they may have oral medications that they take to counteract, right, their effects. Usually they call this before, right? They call this early onset, right? And this was late onset, not so much, right? You will see type 2 diabetes develop in much younger patients, right? If their diet is not optimal, and they'll also have genetic predisposition to develop diabetes. You see, right? Associated with obesity is usually type 2. So this is some of the things that we see, right? So what you want to remember from this, right, is in type 1, there's autoimmune destructions of the beta cells. They are not making any insulin. They're probably going to be prescribed injectable insulin through subcutaneous tissue, right? Type 2 usually are making insulin. They may not be making enough of it, or the peripheral receptors are not as functional, right? And this is distinction. By the way, here's a question. Which of these patients, right, if, they are not taking their medicines properly, which of these type 1 or type 2 can go into DKA, diabetic ketoacidosis?
Both, but more likely in type 1.
I couldn't hear you, Aaron. You said more likely which one?
Both, but more likely in type 1.
Type 1, yeah. So you're correct. And do you know why?
Yeah, because the type 1 diabetics don't create any insulin, so their sugar just always goes up. Type 2 is more of an insulin resistance issue. So their body still makes insulin, but it's just not as effective.
So what you're saying is correct from a standpoint of sugar, but that is not the reason. But that is not the reason why.
Because triglycerides بتكون adipose tissue.
Okay, mainly. Yeah. Helmi's got it. Helmi's got it, right? So it's not because of the sugar that they go into DKA, because in both type 1 and type 2 diabetics, if they're non-compliant with their medicine, if you check their sugar, is going to be high, right? But that is not the reason type 1 goes into DKA, and Helmi's 100% correct. So what happens is the body is thinking it's starving, right? Because there's no insulin in type 1 diabetes. So what it's going to do is going to take its adipocytes and is going to start to break down its fat cells with a process called lipolysis. And this breakdown of fat cells with lipolysis is going to cause production of ketone bodies. And ketone bodies are very, very acidic, right? And that's why these patients go into diabetic ketoacidosis. In type 2, right? Yes, there is insulin deficiency and not as effective, right? Due to the receptors not working. But even though those receptors are not working, there's still insulin that's made. And that insulin that's made, even though it's very little amount, it prevents lipolysis. It prevents breakdown of fats into ketones, right? And that is the main reason why type 1 diabetics, go into DKA, and type 2 usually seldom. And there's something else that happens in type 2 diabetes. They call them a hyperosmolar, hyperglycemic, non-ketonic coma. So they go into a different state, right? They have hyperosmolar state, and it's non-ketonic because they are usually not making ketone bodies, right? So this basically, right, some of the symptoms of diabetic ketoacidosis that you usually see, right? The most frequency, right, is they have increased insulin requirements. The trigger could be either they're not taking insulin or they have an infection, right? So that is what's triggering them to go into DKA. Some of the signs and symptoms you're going to see, right? You're going to see this, right? They say DKA, delirium, psychosis. You could see Kussmaul's respirations, right? This deep breathing to get rid of CO2, right? You may have abdominal pain, nausea, vomiting. That's a secondary from ketone bodies acting on the brain and the medulla, causing this nausea and vomiting response. You see dehydration because they're peeing out all the fluid secondary to high amounts of sugar in the urine, and they have this ketone smell, fruity breath called acetone, right? So if we check their blood, we're going to see high hyperglycemia, right? And we'll see also, right, abnormalities with their electrolytes, especially potassium will be abnormal. How we treat them, right? So treatment, you will have a protocol, right? You have a hyperglycemia protocol. Usually we give them IV fluids initially. Then we give them IV insulin. Does anyone know why we give them IV insulin?
Because you could bring down the blood sugar at a controlled rate.
Right. So anyone else thinks the same? So the main reason we give DKA patients insulin
right into the blood. Right.
Yeah, that is correct. We give insulin. We could give insulin drip, but what is the main reason these patients receive insulin? Is it to drive glucose into the cells? What do you guys think? What do you think? What do you think, Ian?
Geez. Treatment. Yeah, you want it right into the blood so that the process will stop, right?
What process would stop?
The acidosis.
Yeah, so exactly, right? So the reason why you give insulin is not to drive sugar into the cells. That's the byproduct of insulin. The main reason you give insulin is to stop destruction of fat cells, lipolysis. You stop lipolysis. By stopping lipolysis, right, you stop destruction of ketones. And so you reverse them. And then you basically replace the potassium stores, right? So this is usually you see in type 1 diabetics more often. This is you see in type 2 diabetics. This is called hyperosmolar hyperglycemic non-ketonic coma. Usually their sugar levels will be way, way higher, right? And they will have high serum osmolarity, right? But they will usually not make ketones, right? Why? Because they still make some insulin. So because they make some insulin, even though it's not a great amount, it is not going to significantly move the body into producing ketones, right? Helmi, you have a question?
No question.
All right. Do you guys want to know more details about ketoacidosis or not so much? Like, do you want to know the whole process, how it works?
Yes.
You want to know?
I think it's interesting.
All right.
Yeah.
All right. So I will draw it out for you guys. All right. So imagine I'm going to draw a couple of figures here. So imagine this is your circulation, right? And here, right, we're going to say, let me draw inside of it. This is your pancreas. B cells of the pancreas. Right? And we said it was in type 1 diabetics, type 1 diabetic patients. So imagine the following situation. So you have a diabetic patients. One of the reasons they go into DKA, right? So why do they go into DKA? So one could be and the very common form is non-compliance with insulin. So these patients must always be taking insulin, right, to not only drive the sugar into the cells, they must take insulin to prevent the formation of ketones. So one biggest example is non-compliance. A lot of times you see that with very young patients. Let's say, they're under stress, they're having finals, or they just, broken up with their, boyfriend, girlfriend, and they'll say, you know what, screw this. I'm not taking any insulin. Or their thought process could be, I didn't eat anything today, right? So then I don't need to take insulin, right? But the problem with these patients, it's not that they need insulin just to drive sugar into the blood. They need insulin to starve off that ketone body formation. So usually it's non-compliance. And the other factor being is they're sick. So they have a fever, right? They could have, sepsis. They could have trauma. They could have, they just had surgery. So all of this together, you know what this does? All of this together increases norepi release, right? All of this releases norepi release. And I'll explain to you how is that going to be a problem, right? In a little bit. But basically, these are the common reasons why, right? Diabetics, type 1 diabetics go into DKA. So what happens, right? So imagine, let's say I am not compliant. I didn't take any insulin, right? And my beta cells in type 1 diabetes, they are not making any insulin. So no insulin is produced because you have autoimmune destruction. So far we make sense, right? So initially what happens, right? We have our liver, right? And the moment this occurs, right? The liver, you have your, we're going to say this is our fat cells. We're going to draw some muscles. Right? So the moment your body is not getting any sugar, right? The body goes into this mode of like fight or flight. And when it goes into the mode of fight or flight, you have some counter-regulatory hormones that are going to be released, which is epinephrine, which is cortisol, right? Which is growth hormone, and glucagon. Remember we talked about when the glucose is gone, you're going to get glucagon release, right? So we just talked about, right? Glucagon, when it acts on the liver, right? What do you think is going to tell the liver to secrete into the blood?
Fat cells.
So liver's, what is going to break up? So liver has your stores of glycogen, right? So when the body's thinking it's not getting enough glucose, the glucagon is going to work on the liver, and then it's going to send the glycogen to be broken up into glucose. So now our glucose in the bloodstream is going up. Make sense? Right? Also, these hormones are going to work on your muscle, right? And it's going to do what? The muscle, we said, cannot send glucose, but what it can send is going to send amino acids into the bloodstream. It also is going to send lactate, right? Lactate. So you become, goes into lactic acidosis. The fat cells, when these hormones work with them, it's going to go into lipolysis. And what it's going to do is going to basically send fatty acid and glyceride into your bloodstream. And also, besides the fatty acids and glyceride, it's, as the time goes on, it's going to start making ketones. And ketones are very acidic. Why is the body doing all this? Because there's no insulin. And because there's no insulin, this high glucose that's found in your blood cannot be uptaken by any cells. So body inappropriately thinking it's starving, right? It's basically, it's saying like, there's no sugar, we need more sugar. So all these hormones, epinephrine, cortisol, growth hormone, and glucagon, it's working on these cells to basically break up glycogen stores, break up muscle cells into amino acids, break up adipocytes into fatty acids and glycerol and send them into circulation, right? So this is what's occurring now. And so the person, all of a sudden, his blood sugar becomes, let's say, 200, 300, let's say 300 milligrams per deciliter, right? But the problem is not there yet, right? The sugar is going up, but the problem is not because of the sugar. It's not the sugar that's going to kill him. You have, as the time goes by, this accumulation of ketones, right, is going to make his body become more acidic. So this is what's causing him become more acidotic. So as the person becomes more and more acidotic, right, you're going to see his blood pH starts to drop. So normal blood pH is 7.35, 7.45. So here they may start go below 7.3. So pH starts to drop, right? And this happens because you have high accumulation of, right, hydrogen ions, right, from the ketones that are coming in, right? Now, the problem is still not there yet, right? We're continuing. So what you see on these patients, we're going to say this is his nephron, right? And this is where you make your urine. So he has a lot of sugar, right? That's now starts to leak in his nephron. So you have a lot of glucose that's coming into the nephron. But the body cannot reuptake all this glucose. All of a sudden, he starts to make a lot of glucose in his urine. So we call it glucoseuria. Right? So the patient starts to pee out a lot of glucose with his urine. And guess what, right? Because this urine becomes very high in concentration of this glucose, it's going to pull water with it. So it takes water with it. So you have high losses of water along with glucose. We call it osmotic diuresis. So you have a person right now, right? As this is going on, they're becoming more acidotic, right? Because the body's making a lot of ketones. They are becoming, right, more and more hyperglycemic because the body is breaking all these glycogen stores, muscle stores, and fat stores in the body, right, in order to preserve life. This excess glucose is spilling into the kidney, and kidney is peeing out this glucose along with water, and it's making glucoseuria with osmotic diuresis. So the person is losing a lot of essentially fluids along with their sugar. So, and so what are problems that you're going to start to see with this, right? So one of the problems that you're going to start to see with this high amounts of hydrogen that's in your blood, right, that's coming in from these ketones, right, is going to, in the blood, we said there's bicarbonate. It's going to meet with bicarbonate. It's going to make carbonic acid, and this carbonic acid is going to dissociate into CO2, right, and H2O. And this CO2 is what's going to be breathed out by the lungs in order to preserve, right, you at pH balance, right? And we say, right, the person has what type of respirations when they're breathing excessively to get rid of CO2? Kussmaul, right? Yeah, they'll have Kussmaul respirations. It's deep breathing in order to get rid of this CO2, right? Where's the CO2 coming from? It's coming from ketone bodies, the hydrogen that's mixed with bicarbonate that became carbonic acid, and the CO2 is being eliminated by the body, causing Kussmauls, right? Also, ketones, one of the ketones is called acetone. So one of the ketones is called acetone, and this acetone is also going to go in being released in your lungs. So you have this acetone fruity smell, right? Fruity smell from the acetone, right? So it makes sense, right? So Kussmaul's respirations, you're trying to get rid of this hydrogen via CO2. You have fruity smell with the acetone, right? Another thing that you're going to develop, right, in your, let's say this is your GI system. If you're peeing out a lot of sugar with water, right, do you think you're going to become thirsty? Right? So you're going to become thirsty and you're going to become hungry. So this is going to cause those polyuria and polyphagia symptoms. Right? So polyuria, polyphagia, right? And polydipsia. Let me write it here so that you see. And they call it the 3 Ps of DKA. So polyuria, making a lot of urine, and that's what's going to make you polydipsia become thirst increased, and polyphagia increased hunger. And this is urine production, right? So all those byproducts of DKA that's coming, right? So far we haven't provided any treatment for this person. The whole thing started out, right? They were either non-compliant with their insulin, or they developed fever or sepsis, or they had trauma or surgery, right? And this causes body thinking it's starving. When it's thinking it's starving, it's going to secrete its counter-regulatory hormones, which are going to act on, right, let's say on the liver to release glycogen stores. So you have high glucose now forming in the bloodstream. It's going to act on the muscle to start breaking muscles apart, right, into amino acids, and also into lactate production, lactic acidosis. It's going to act on the fat cells to basically break up fat cells into fatty acid, and they're being supplied into the bloodstream, right? And as this time goes on, the body also starts to make ketones, and ketones are very acidic, right? They drive the pH down to less than 7.3. For your body to counteract that pH, is going to basically combine the hydrogen with bicarbonate, make carbonic acid, right? And hopefully you could blow it off as CO2 with Kussmaul's respirations. Also, one of ketones is called acetone. That's why you have the fruity smell, right, that's coming in. This excess glucose being dumped in the kidney, it's going to cause osmotic diuresis. So this is what's causing polyuria. A lot of urine is being released. And a lot of urine that's released is going to make you thirsty, is going to make you hungry. So you develop polyphagia, polydipsia, the 3 Ps of, right, diabetic ketoacidosis. And what do you think the treatments are for those patients? Let's say you arrive to a call, you check someone's sugar. Let's say their sugar is 350 milligrams per deciliter, right? You're told they have diabetic history, they have type 1 diabetes, right? And you're told, right, they had a fever, right? Maybe the person is septic, right? So they have sepsis. You have a person like this, they alter mental status, they're breathing very fast. You see Kussmaul's respirations, you smell some fruity breath on them, right? And you see they're incontinent, they're peeing out, they have loss of a lot of urine. So what do you think would be some of the basics in terms of treatments?
Fluids and oxygen.
So fluids first, right? To replenish their stores, oxygen and airway management from your perspective, right? So you take them to the hospital, you give a notification. This person arrives to the hospital, right? Besides the fluid administration, what do you think they're going to do in the hospital based on what you learned so far?
Insulin administration.
Insulin, very good. And why do we what's the main reason to give insulin?
C-peptides.
Huh?
For the C-peptides.
What were you saying, Helmi?
For inhibition of lipolysis.
Exactly. Excellent, right? So the reason you give insulin, you want this is to stop. You stop the lipolysis, there's less, right, fat cells that are being destroyed, and there is less ketone formation. So basically you drive the ketone formation down, right? So insulin is given intravenously. Again, the major purpose to stop lipolysis, it's not to per se drive the sugar into the cells. And the other thing, right, that they're going to also do for them in the hospital is basically to correct their electrolyte imbalance. Usually what happens, remember I was telling you all cells in the body are what? They're bags of potassium and the sea of sodium, right? In the setting of DKA, right, when you have high hydrogen content in the blood, right, this hydrogen can exchange in the cells for potassium. It's basically one of the body's ways to try to combat this acidosis. So hydrogen is going to go into the cell and it's going to dump potassium into the bloodstream. And that's what's causing, right, hyperkalemia in these patients. So if you check their potassium level, they have hyperkalemic state, right? And usually the way you correct this is once you start giving them IV fluids and insulin, right, the potassium will start to actually reduce, and these patients will need to get potassium replenishment. So they'll need to give them potassium IV, right? They do it slowly, but in the initial phases, if you check their sugar, if you check their potassium level, it will be very high. They will be in hyperkalemic state, right? So essentially, this is the treatment, right, and the pathophysiology of DKA, right? Any questions about this one?
Hey, Nick, I had a patient today with hyper K,
Yeah.
and I think the nurse treated them with packets of, is it glucagon in the water, the powder?
Glucagon and water. No, don't.
Well, you mentioned that they treat this hyper K with some kind of powder. Do you remember the name of?
Maybe they shouldn't. Was it K-oxalate?
That doesn't sound familiar.
They should not. But to the major treatments, right? As I said, right, IV fluids to replenish the losses, IV insulin to stop lipolysis, and usually they replace potassium. They usually give potassium. They could give orally, but usually it's done intravenously. It's done slowly, and that's to basically replace those potassium stores. Why? Because the moment you start giving IV fluids and insulin, right, that potassium is going to be driven into the cells.
Okay.
All right. So usually that's the treatment from your purposes as a paramedic in the field. If you have a patient like this and you determine they have DKA, your primary goal is fluid replenishment, right? IV fluids. You're not going to be correcting their electrolyte problems. Your other major thing is airway management, right? Perhaps they're altermental, right? So you may need to, bag them or give them oxygen via non-rebreathing mask. You also want to be cognizant these patients can have vomiting, right? The reason why they have vomiting is ketone bodies act on the medulla in the brain and they stimulate vomiting, right? So that is medication Zofran, right? You carry ondansetron, Zofran. So that can be given to them if they have active vomiting that's going on to prevent, right? And active vomiting on the person who is altermental may send them into aspiration. So maybe you would even go to the point of intubating them to control their airway management. Right. And the other thing is, right, you check their sugar level so you know what's going on. You want to get the history in terms of what they believe or the family believes was the trigger. Usually it's non-compliance or infection can cause all this stuff to occur. And you want to make sure you write it down. A patient's one thing that, diabetics, especially type 1, right, they should always be taking insulin. Why? It's not just to drive the sugar into the cells, it's to prevent this lipolysis and ketone body formation. That's why a lot of younger patients, they may, let's say they didn't eat, they'll say, okay, I don't need to take insulin, right? Or they have some, arguments that go on, they go on a strike. They say, like, I'm not taking my medications, I'm not taking my insulin. So then you are cold, right? And they're at a point in DKA, right? So that's something you want to, be cognizant about. All right. Any questions about this? All right. And the other one, right, in the type 2 was hyperosmolar hyperglycemic state. It's basically the state is similar, right? They're also going to have this thirst, polyuria, but the major distinction is they're not going to show low pH. They're not going to have ketone production. Why? Because they have insulin. So this is usually in type 2 diabetics, right? If they're not compliant with their medicines, right? In the hospital, they're still going to give them IV fluids, right? The insulin therapy is going to be provided, right, as necessary. And then education in terms of compliance with the medication. These patients will have excessive osmotic losses. Why? Because these patients will have their sugar in excess of 600, or you will see high written on your glucometer, and they may be incontinent, so they'll lose a lot of urine. And you are definitely doing same treatment, right? IV fluid therapy, oxygen therapy, and notification to the hospital.